Hello, everyone. Welcome to another Community Conversations by the Center for Black Equity. Um, Thank you all for joining us today. This is going to be a special conversation in honor of Southern HIV/AIDS Awareness Day. Um, we partnered with the Capitol Ballroom Council to really make sure that we can have a broad audience to get this information. Um, you know, Equity, first of all, I'm Kenya Hutton. I'm Deputy Director of the Center for Black Equity. I just started talking like we've been old friends, right? Um, so, equity is supposed to be for everyone, right? But we're really not seeing it as being that evident in the South. Each year on August 20th, advocates, allies, practitioners, and most importantly, survivors in the South recognize Southern HIV/AIDS Awareness Day, also known as SHAD, which is a day implemented to raise awareness and address the impact of HIV in the Southern states. Right, it's important to actually acknowledge the advancements made in things like in the fields of HIV, such as PEP, PrEP, and ARTs becoming more accessible. However, what we're noticing is that we can't ignore the elements that chip away at these advancements, such as stigma, racism, implicit bias, you know, it's and discrimination. While many communities are moving forward, but in the epidemic, the South continues to trail behind other jurisdictions, which is unfortunate. Southern states account for 38% of the U.S. population, yet 45% of the population is made up of persons living with HIV. In 2020, there were about 481,815 people living with HIV in the South, and of that, 15,661 people were newly diagnosed, accounting for 53% of new diagnoses. African Americans continue to be disproportionately affected by HIV in the South. So this is going to be a great conversation. I'm going to go ahead and get us started by introducing you all to our moderator today, Torian Baskerville, Director of HIV and Health Equity at HRC.
Hey, Kenyon, thank you so very much for the introduction. Hello, everybody. Again, I am Torian L. Baskerville, Director of HIV and Health Equity at the Human Rights Campaign, Foundation. And so I am super excited to be a part of this conversation in honor of Southern HIV and AIDS Awareness Day. And I'm super excited to have our panelists today to have this important conversation. So first, I'm going to allow everyone to introduce themselves, but I am going to start with Dr. Fanfare.
Oh, there I am. I was like, oh, I'm still backstage. Hi, Toria. My first time using this. Hello, everyone. I am Robin Neville at Fanfare, and I'm coming to you from Atlanta, Georgia. I am the acting director in the Division of HIV Prevention here at CDC. Good afternoon.
Thank you. Next, we have Dr. Tatiana Moten.
Hi, good afternoon. My name is Dr. Tatiana Moten. Hi, Robin. I am the Senior Strategy Advisor for San Francisco Community Health Center. I am here in Atlanta, Georgia. I am really happy to be here today.
Welcome. Next up, we have Jeffrey Campbell.
Good afternoon, everyone. It's my pleasure to be with you all today. Hello, Torian. My name is Jeffrey Campbell, and I am the Chief Executive Officer of Allies in Hope, formerly AIDS Foundation Houston. We're located here in Houston, Texas, and we have been doing this work for 41 years now.
Thank you. And last but certainly not least, Carmarian Anderson Harvey.
Well, hello there. Hello, friends. And to my direct colleague, Torian, I'm Carmarian D. Anderson-Harvey. The required pronouns is she, her, and hers. I am the Alabama State Director for the Human Rights Campaign, and it is an honor to join this esteemed panelists around this conversation and the diversity that we will offer on today through our responses. So thank you for this opportunity.
Listen, I am among giants and leaders in this work, and I am just privileged to be in this space with some familiar faces and some new faces. And so let's jump right in. I'm going to start with Carmarian. What challenges do you observe that are more heightened in the South than other jurisdictions? And what tools are needed to overcome them?
Yeah, so when we speak about the South, let me also preference that, we have Southern initiatives, but there's also some deep Southern initiatives that I call those that live in the Bible Belt sector of the United Shades of America. And why I preference that, because my response is going to be because of the barriers that we continue to face to reduce the epidemic numbers around HIV, as well as an uptick into access and treatment. Being that we are part of the Bible Belt, there are still a lot of closed doors, a lot of biases, and really a lot of traditional initiatives that is not getting to the priority population that we need to reach in order to end the HIV epidemic in the South. And so one is when I look at the work that we, not just HRC through our HIV health equity, but also from a health department, the End the HIV Epidemic Plan, the CDC initiatives. One, I want to start with representation. Representation is so important. As a Black woman of trans experience, I only can wear so many lashes. You understand when I say that, right? And so we have to start identifying those gatekeepers that have been trusted by those diverse community members in order for our message to get out into the world, that is going to increase uptick in testing and care, and as well that's going to help reduce stigma. The second is still around visibility. Where are your diverse people that is at the decision table, whether that's by employment and on the board, so you can have real time life experience to your objectives? Because unfortunately, I'm seeing that we are continuing to recycle things that we did 5 and 10 years ago, and it's not meaning us any good. And we are still getting the money for it. Let me just say that. They said I can be honest, and so that's just what I'm going to be able to bring. I think the final piece is that doing a formative evaluation. The beauty about diversity is that if you go out into the community, you will realize that people's first language is so critical in trying to provide services that is going to reduce stigma in the South, okay? And so we may not use the same public health terminology that we're in the community, but it's going to be important that we understand how they articulate in order for us to be able to connect with them tangibly. I always like to use an analogy. I can give Dr. Moulton a hug all day, every day, but does that hug come with some level of embracing? And so that is what we're kind of missing is that we need to connect in such a tangible way that it feels like we are embracing, and that embrace is going to allow us as service providers to have empathy, and as well take their testimony, take their I statements, and take their narratives to the table of our decision and planning, so we can reduce stigma, the onset of the epidemic numbers of HIV, and as well as the uptick of access and treatment in the South, particularly the Deep South, prioritizing our priority population.
Thank you for that, Carmarian. Yeah, you spoke on something that is vitally important as we talk about ending the HIV epidemic in America, right? Stigma, right? And we all know doing this work that stigma plays a major part in the HIV numbers, and also why, some responses aren't what we would like them to be, right? And so with that, I'm going to go to Jeffrey next. So stigma continues to serve as one of the biggest deterrents for people seeking HIV testing and treatment. What strategies are being implemented to combat the effects of stigma?
So thank you so much, Torian, and again, thank you for having me on this panel today. I think Carmarian did an excellent job of speaking to stigma, but I want to talk about a few things that I think that we're attempting to do in regards to stigma, and that's first and foremost ensuring that we have a board representation of people who are part of these communities that are most impacted by HIV. I think the other thing is leadership within the organization. What does your leadership look like? So I shared in my introduction that this organization, Allies in Hope, is 41 years old. And I am the first African-American CEO that we have ever had. And I became the CEO in March of this year. So I think that's a step in the right direction. Our board chair just happens to be a Black, same gender loving man. We have worked over the last 3 to 4 years on ensuring that our board representation is diverse, not just for the sake of being diverse, but diverse in representation of the communities that are most impacted. And I believe when our communities see us in CEO roles, in board chair roles, in our medical doctors and our nurse practitioners and our nurses or other nurses, that they are seeing us, not just Black folks, but it's particularly important in Texas that they're also seeing Hispanic Latino individuals that are bilingual, that are able to speak both English and Spanish. That's important in Texas. That's important in Houston because it builds trust in your organization. People are less likely to go to an organization where there's nobody there that looks like them. However, on the other side of that, people are challenged by going to organizations, to clinics, to community business organizations that are HIV prevention centered, where they may see someone they know. And so, I think all of us probably know someone who died as a result of stigma. Stigma should have been on that death certificate because they didn't want to go get tested. They didn't want to go get treated, and they died. But I think we're doing the work of presence, ensuring that our faces are seen doing the work. I think it is also important for us, beyond the board, beyond the CEO, who's at your front desk? How have they been trained to receive the folks who come in on a day-to-day basis? Are they going to speak? Are they going to be able to communicate with that person that walks in the door, and in order to properly identify them in regards to that person's gender identity? And are they going to be able to be comfortable with that? How much more training do they need? What are your primary care providers that are, seeing folks in your patient examination rooms? What's the conversation that they're able to have? Are they culturally appropriate regarding gender identity, sexual orientation? Those are all significant things that contribute to destigmatizing our communities around HIV, STIs, and even gender identity and expression.
Thank you for that, Jeffrey. You brought something up that around that duality, right, of wanting to see someone that looks like you, but then also kind of that fear of like not also wanting to see somebody that looks like you or somebody that right? And especially when we talk about the rural areas, right, in those places where it's like my auntie works at the health department, right, or my mom's best friend lives there or works there, right? And so working through that and how that shows up in these spaces. I want to shift to Dr. Fanfare. So, we've been impacted by a pandemic, epidemics, all of the things, right? And it has changed how services and resources have been accessed. So, and shortly after, we were thrusted into a pandemic, right? Having to navigate resources for HIV, for Mpox, for opioid use, and hepatitis C. What is the landscape of services like for people accessing services and resources in the South?
Thank you so much, Torian, once again for having me here as a part of this esteemed panel. I think, just as you alluded, really the landscape of healthcare has definitely shifted over the past 3 years in the midst of pandemics and several syndemics. The South continues to have the highest number of people living with HIV. And we know that in the South, people are more likely to be uninsured compared to the rest of the country. When we look at states that chose not to expand Medicaid, there's a fair amount that are included in the Southern states. So the South continues to experience the greatest burden of HIV and deaths of any US region. So, a couple of things that I'd love to highlight when we talk about what the landscape looks like now. I also serve as a provider for veterans living with HIV, and so I'll speak kind of from that provider perspective. Um, the impact of housing really cannot be understated. It's a quality of life issue. It's really a right, and so many individuals who are either living with HIV or vulnerable to HIV are in situations where stable, safe housing is beyond the reach. And I think really being able to find a way that we can impact that and other social determinants of health, but housing is so critical. I think Jeffrey may have alluded to this as well in his remarks. Um, our workforce. When we're talking about the landscape, our workforce is so important, whether it's our public health workforce, whether it's our clinicians, whether it's our community-based workforce. It can't be overstated how much of an impact the past 3 years have had. People are burnt out, people are exhausted, people are getting sick and ill, and even worse. So really thinking about if we want to be able to end the HIV epidemic, we have to be able to pour into ourselves as fighters in this work. Is really important to be able to make sure that we have people coming behind us, and that pipeline is robust. So I think the workforce is really important. Another thing that I want to take out as far as the landscape are some of the positives, right? Some people didn't love going to clinic, didn't love the clinic where they were. So it really pushed us to kind of break down those traditional clinic walls and think about ways that we could meet people either where they are or where they want to be met. Right. And so for some people, it might mean an HIV self test kit that I can go and order online and get delivered to my home. For others, it might mean teleprep or telehealth services and being able to do that from the confines of a safe space for them. It might be mobile units, right? Or it might be going to some community based organizations where they have trusted messengers and people who they trust and believe in. So really thinking about ways to continue to support but also find ways outside of the traditional clinic models, I think, is a landscape that we've been pushed into after COVID-19, and would be nice to continue some of those innovations.
Yes, thank you, Dr. Fanfare. You said a couple of things that stuck out to me that I had to make note of. And one of the things you said was stable and safe, right? And you talked about it in the context of housing, right? But I think about it, I thought about it right, like we all want to feel stable and safe, right? Not just in housing, but physically, right? Mentally, financially, right? Emotionally. And so I think thinking through that lens too, right? Like stability and safety is important for all of us. And how do we champion that and center that, right? The other thing that you talked about and that resonated with me was essentially talking about equity, right? Like, how do I see the people in front of me, the people who I need to prioritize, right? And how do I meet their specific needs at the moment that they have that need, right? Because what I may need today may not be what I need tomorrow, right? Even if my need didn't get met yesterday, that may not be the same need that I have today, right? And so understanding that. I think the last thing, and I'll use this point to transition to my next question, is around the non-traditional approach, right? And the need to not do things. And Carmarian kind of talked about this in her response, right? Like not expecting that what happened and what worked 10 years ago is going to work now in 2023, right? But how do we look at these things in non-traditional ways? And so that brings me to Dr. Moten and the next question, right? So there's a quote that says, "No one is coming to save you, but your own hero." And so, traditionally the LGBTQ community has had to curate a foundation where we save our own members, right, in our own communities. And time after time again, right, this has happened. We saw it last summer with Mpox response, right? Talk about the contributions specifically for the ballroom community and what they've made to help the HIV epidemic.
Absolutely. Thank you for that. And thank you again, Dr. Robin, for all of the things that you said. And I think it's very important to highlight that, particularly within the ballroom community, there are many things that we have recognized that we had to do for ourselves. And if there's one lesson that was learned, particularly for myself, being both a CBER provider, which is the capacity building assistance provider, funded under the Centers for Disease Control, but also being a participant of ballroom. I am also a leader in ballroom. And so from the beginning of this epidemic of HIV and AIDS, we have had to respond to our own. And so creating safe spaces for chosen family members and other individuals that were impacted or directly or indirectly impacted by this epidemic, promoting HIV education and AIDS awareness throughout our own communities without any assistance from other entities, and creating campaigns and being the purveyors of those campaigns and leading them and implementing a lot of these homegrown interventions, if you will, for ourselves, because we recognize that as much as within society we are seen as living in the margins, we still have to show up for our people. I am the mother of 21 chosen children, 17 here on earth and 4 in heaven. And never once have I been able to go in and say, hey, I need assistance with this, or being able to attend those medical appointments early on in the epidemic because they didn't recognize those non-traditional family dynamics. And so I am really happy and to see that our federal partners are now recognizing these things. And even as you talked about with the response to Mpox, it was to us that they came first, and trying to figure out those things. And so, as I said, one of the greatest lessons that came from COVID that I learned was get out of the way and allow community to help community, because most of the answers that we're looking for, we already have. And so also encouraging HIV testing and prevention. I'm one of those parents who encourages PrEP. I am one of those parents who encourages my children to get in care, to re-engage into care. And so when we're talking about public health initiatives, I think that it is intuitive of us to look to a lot of those non-traditional mechanisms, because again, like as I said before, a lot of those answers that folks are starting to try to theorize and try to understand, okay, well, where does this fit? And what are the theoretical foundations of this and all of that other stuff? And we're saying we have tried those things, as Parmerian said, 15 years ago. Going into barber shops and beauty shops and having those conversations about HIV and AIDS awareness and prevention, we've had those conversations. And so looking to a lot of those non-traditional mechanisms and frameworks of how we do prevention and care should be utilized. Supporting those that are living with HIV. For individuals that are living with HIV within the ballroom community, we've created networks of services and care. Hey, I can't get my medication over here at this clinic. You have a person that's, and even as much as we hate to say this, also the sharing of medication happens where persons who are not able to access or obtain those things, PrEP, PEP, where folks are not able, and having the experiences of having providers say, I don't feel comfortable with prescribing you this medication. Where is it that they will go? Yes, we can say on, all of the reasons why we wouldn't want to do that. But for us that are in community that are saying, as you said, no one is coming to help us. We have had to figure out a lot of these things for ourselves. And so outside of that, advocacy and political activism, we are very much so involved in a lot of those things. And thank you again to the Capitol Ballroom Council for doing this and raising and elevating the voices of those that are within communities and those that are leading these charges. So in a lot of ways, we are having to activate ourselves without resources, under-resourced, and, so trying to figure it out for ourselves, fostering resilience and empowerment, because we're not just a community that has been impacted by all of these things. We know they exist, but yet we still have to face what it is that is our reality today. As I said, I have had 21 chosen children. I never had the opportunity to have a bad day. And so in those moments, those resiliencies and those stories of resilience, those are shining through, because to those children and those other people that have those touch points with me within community, both within ballroom and within the public health sector, they are still coming to me, not to say, okay, hey, wait a minute, I want to take a moment of sadness here. No, What's important is that I need resources. I need to be connected to housing resources. I need to be connected to medical care. And all of those things have to happen for our people, for our communities. And then aside from that is memorializing and honoring the lives that have been lost to this epidemic within our community. As we've seen how heavily impacted the ballroom community, many of our pioneering icons, our icons and legends, and even those folks who are just making impressions, on a daily basis, are continuously being lost to this epidemic. And now, as you talked about with the syndemics and the multiplicity of all of these pandemics that are occurring, our people are still being impacted. And even in this country, I'm one of those persons who says, as we're having conversations about health equity, we have to acknowledge that we're talking to communities who have never experienced health equality, because equality dictates that we all get the same. And so for many of us, we've never even begun to get to the starting line. And for those of us that are in ballroom, what we're saying is that we have a multiplicity of identities that we vacillate through every day. Most of those are traumatic, and there's a lot of compounding trauma, a lot of the disparities. And COVID didn't create these disparities. COVID only highlighted what existed already. And so for us that are solutions oriented, we know the problems exist. And then we say to those individuals that have the power to change those or have the ability to influence that change, what are we going to do now? We're not going to sit here and talk all day about what exists, because when we're looking at the numbers, 43% of transgender women of color that are living with HIV are situated in the US South. That's alarming. That is almost half of the Black transgender population in this country. And so what we have to say to ourselves is, what are we going to do about it? We have to begin by creating homegrown interventions, public health strategies that are very specific to Black transgender women. If we are saying that this is a priority population, then let it be prioritized.
Dr. Moten, so many great gems in your response. So thank you for that. I really love, what you said, that, we are trying to, create and build equity for individuals who've never experienced health equality, right? They've never had a certain standard of care in their health systems, right? I love that. And also talking about too, right? Like mistrust, right? You talked about that piece in not in a direct way, but really like how, sometimes again, our community has had to respond to the needs of our community because we didn't always trust necessarily other systems that we should have been able to do so, right? I also appreciate you bringing up about the sharing of medication. I recently had a situation where someone reached out to me because they were in transition between jobs, right? And was like, hey, I only have a week of medication left. What do I do, right? And so, we have always had to reach into our networks to find what we can to meet our need, responsibly, of course, but also do it anyway. And so thank you for that. My next question, I'm going to Carmarian and Jeffrey next. How has the Black church been instrumental in the HIV movement in the South? And I'm going to also add too, how can it be instrumental, right? Not just what it's been, but also how can it be in the future and current? So Carmarian, Jeffrey, whoever wants to go first.
Paper, scissors, rock, Jeffrey.
I'll let you go.
All righty. Well, we understand that this is my lane. I was glad when they said unto me, let us go into the house of Black church. Jeffrey and I can speak about this all day. I consider Jeffrey my pastor in Houston, and we're clergy colleagues and have had this conversation around HIV and Black church, particularly in the South. And so, one of the things I wanted to define, and I appreciate that probing question, that second question that you included, Torian, because when we talk about being instrumental, we have to define this word instrumental in this sentence of Black church. And instrumental to me is serving as a means for an outcome. And that's what I want to kind of speak about as it relates to the Black church. So let me first start with some accolades. I'm appreciating that there are clergy, men and women and humans that understand intersectionally that they must talk about HIV in their congregation. There are health ministries that I have been privy to and actually have supported that actually have a framework to reduce stigma in Black church and test their congregation, including the pastor, all the way down to the laity, so people will know their status. And we need more brick and mortars and more ministries that will jump on the clarion call that, you know, we must take what in Black church we call the Bible of theology, and also along with that Bible next to it have the newspaper, because the newspaper will give you some statistics around data and what's happening within our community that we often don't bring into the church. So a couple of things that I want to be able to highlight is you know, I grew up good old charismatic Pentecostal, okay? So King James was my life. And so not to give you a sermon, but it does not do me well that if I can get up and pray for every other communicable disease, such as diabetes in the Black community, and hypertension in the Black community, and sugar levels in the Black church, and leave out the healing of HIV and AIDS. Come on, somebody. We have to include that and to follow that up contextually with the scripture. Now I'm talking to those, because in the Deep South, it is very high priority Christian centric. And there is a scripture that we can hermeneutics to our individuals to educate them about HIV and advocate for those that are living with HIV, that the sickness is not unto death, but it is for the glory of our universe to know that we can still thrive and be human, and that what the enemy or what the naysayers or however HIV came upon you, that you will live and you shall not die. That is a testimony, and we have to offer those opportunities in those spaces. The other piece that I'll say is that for my clergy colleagues, we got to be okay to start talking about sex and Jesus. We can do that in the same breath, because when you don't speak about it, it is happening. And then at the last minute, when they share with you the outcome of what you did not prepare them for, you're not prepared to give them pastoral counseling. You don't even have a referral guide. You're not even a licensed, social worker. So we're doing a disadvantage. So we have to have certain things in our congregation to prepare in the time that we're in. It is okay to talk sex and Jesus in the Christian church, in the Black church. It is okay to talk about condom use, that it is a protection for this body that we say is the temple here in the earth. It is okay for us to hermeneutics in a way that will get the attention. So in Black church, our data will celebrate the reduction of stigma, and we can celebrate life more abundantly. So that is my response to Black churches, is that we have to increase our knowledge around current events, and part of that current events is HIV, because we shall live and we shall not die because of HIV. Jeffrey?
Hey, look, thank you, Elder Reverend. So just a little peep into why this question was thrown at me. I am a licensed and ordained minister, have been so for, since 1997. And grew up in the Black church, more independent minded at this point. I have a strange relationship with the church now. But the question that I'm seeing is, how has the Black church been instrumental in the HIV movement in the South? So I want to speak specifically to a few churches here in our area. So the Brentwood Baptist Church has a foundation. And for almost 30 years now, that foundation has been the umbrella for housing program for men living with HIV, and that it's HOPWA funded, housing opportunities for people living with HIV. I'll tell you, when Brentwood proposed building that housing program, that the community, the homeowners association, protested it, and the city took the money back. And the pastor of Brentwood, Dr. Joe Samuel Ratliff, stepped up and said, yeah, no, we're going to fight. And so they fought, They won. And so that housing program has been standing, and it has been a safe space for Black and Hispanic men living with HIV, regardless of their sexual orientation, for almost 30 years now. I think that's an important mention. I think it's also important to mention St. John's downtown, which is a United Methodist Church, that for almost 30 years now has actively hosted a Get Tested Sunday every fourth Sunday in the month to promote testing, not in a secret way, but to have the leader of their HIV services ministry to get up on stage every fourth Sunday and say, hey, we got testing in the back. That's a partnership with some community testing providing service organization that provided testing and education and linkage to PrEP care and linkage to not primary, but HIV treatment and services. I can mention those two churches. I talk about Reverend Edwin Saunders in Tennessee, that for many years has been the face of the Black church at many conferences across this nation. So churches are doing. What I am seeing, though, and I think it is across the board, is, we've gotten in a really great place, I think, with HIV. We haven't ended the epidemic in Texas or even in Houston. We have not found a cure. We have not found a vaccine yet, or it have not been discovered. But I think in that, because we have the science that people living with HIV are more healthy, that churches and Black folks think, oh, that's not a problem anymore. And so because of that, and I would also, it contributed to the COVID, the pandemic, when churches were not able to meet physically, they went online, they met. Some smaller churches disbanded, but we've lost the energy that we had around health and wellness with a specific focus on HIV. In my role as CEO here, one of the things that I have started to do is plug back into the Black church, getting appointments with pastors, getting churches to sign on with MOUs for projects that we are building up that specifically are targeting Black cisgender and transgender women, because that's how I got drawn into this work. I was volunteering and doing some service work with Black women at our Harris Health clinics, and I saw Black women, and this was 25 years ago. And I'm like, I'm in church every Sunday, and there's a lot of Black women in church, but we are not talking about HIV in the church. And so I think what I've learned. And what I'm practicing now, I'm not approaching pastors of certain age anymore to have conversations with them about what I believe the church needs to do, particularly the Black church. I'm approaching younger pastors. I'm approaching more progressive pastors because they're more open to the conversation about HIV. And I'll say this, the way HIV entered our community, or the way we at least think it entered our community, with a high number of Black gay men who were part of the church, who were part of the choirs, who were deacons, who were pastors, that shook the church, because the secrets that the church thought they needed to keep were no longer able to be kept. And so it led the church and put the church in a mode of defense. And in being defensive, the church became offensive. And so I think now it is important for us to really partner with the church, educate the church, update the language of the church around HIV so that they are speaking 2023 language when they speak it, or when they are bringing folks in to educate their health ministries, their young adult ministries, their youth ministries. The church has to be brought into 2023 to do this work in partnership with us now.
Thank you both. Y'all took me to church. I'm over here like, amen, amen. I am going to take a second for a moderator privilege, right? And Carmarian, you said something that I would like to expand on, right? You said it's okay to talk about sex and Jesus, right? I want to take that a step further and say, it's okay to talk about pleasure and Jesus, right? To talk about pleasure. Oftentimes we talk about sex, but not pleasure, right? And so I think that's, we can do both as well. And then also just thinking about language, and we've been having some conversations about language, and I it's always a little dicey when we talk about the Black church and talking about HIV. And one thing that I've always found helpful is framing it from a health and wellness perspective, right? And including HIV in the health and wellness perspective, right? To your point, Carmarian, we can talk about diabetes, we can talk about high blood pressure and all of these other things. But, when it comes to HIV, oftentimes we get silent. And for all of the reasons that you all talked about, and a lot, and also because I feel like we shy away from pleasure, right? We don't want to talk about pleasure. So I'll go now to Dr. Moulton. What does the landscape of HIV services look like for Black trans women in the South, right? You talked about how Black trans women are impacted disproportionately in the South. What does that landscape look like?
It's interesting because I just was, Carmarian and I were just on a panel talking about this very thing, the experiences of Black transgender women that are living in the South. And a lot of those barriers and accesses to healthcare. According to CDC data, Black transgender women had an HIV prevalence of 62%, while Hispanic and Latina transgender women had a prevalence of 35%. And so think about that. Yet again, CDC recently released an issues brief that said 2 out of 4 transgender women transgender women of color specifically. And the reason that you will hear myself and other folks of trans experience say that is because we have to say that with specificity. Because when you talk about the nuances and the experiences of persons that are of the trans experience, it is very different. And that may vary by locale and, a lot of other different kind of situations and things that contribute to those. But you have to be very specific. And even in transgender women of color, I am a Black transgender woman. And so when you're talking about transgender women of color, that includes the entire spectrum of folks that would be classified as of color. And again, it's alarming to me when you say 43% of transgender women of color that are living with HIV or living with the diagnosis of HIV are living in the Southern United States. And so Carmarian and others have kind of talked about stigma in a way. And, I am a person that feels that is one of the keys to moving us towards getting to zero, is addressing stigma in all of its ugly parts, both from an institutional standpoint and from a personal standpoint. And even as we have conversations about HIV, and my sister Carmarian touched on this a bit, about us normalizing the fact of talking about HIV. I'm a person that says we are all HIV possible. And so when we remove that HIV positive, HIV negative, and we say we're all HIV possible, we open up an entire conversation to folks that say, well, wait a minute. Whether I am currently living with or indirectly impacted by, it is a possibility for all of us. And so the ways that we have those conversations with each other, I think are important. And so one of the ways, again, that we're going to address that is addressing stigma from a multi-pronged approach and perspective, because we know that the experiences of stigma cannot be just equated to one thing. If I could put my finger on it and say, okay, this is how I'm being stigmatized, then what really am I saying? Because a lot of those experiences that I am having may come in ways that are not readily identifiable even to myself. When I enter into a clinic and I'm being stigmatized, one, is that becoming because I'm a Black woman, or is that because I'm a Black woman of trans experience? Or is that because I'm a person who is living with HIV? And so once we start to dial down into that, and address, like I said, stigma from that perspective, then we can start moving that needle towards a conversation of, if you will, getting to zero. Because what does that really look like? Because again, if we are trying to have conversations about HIV and HIV prevention and everyone is not at the table, we've left an entire segment of the population out, even in the conversation of PrEP. We're entering into a conference season where Black women are being highlighted, but what are we saying in essence? Black women have always been a part of this epidemic from the beginning. And so even as we're fighting yet again for equity or some semblance of equity, we have to do a level set and say, this is where we are. Acknowledge the trauma, acknowledge the institutional hurts that have happened to our communities, and acknowledge a lot of the ways that we have been over-resourcing in some areas without ever doing a comprehensive needs assessment. What are folks' needs in these areas? Have anyone ever asked that question to anyone? And most of the times we're just throwing resources on the fire, if you will, without saying, wait a minute, what is it that you need so that you are successful in this fight? My dear sister, Tori Cooper, who is not on this panel today, she says, allow folks to be the experts of their own experiences. Start there. I can have a conversation with you. And if I want to have an understanding about what it is that affects you and what it is that you need, who better to ask than you? So I don't know if we lost. Okay.
Yes. Corona's having some connection issues, so I'll come in as well. First of all, thank you for that. Thank you for the discussion, everyone. This has been enlightening to hear from everybody. This has been great. I mean, and everyone on this panel, I love hearing you all talk. Before we move on, Dr. Fanfare, would you like to share something with that for that question or any response?
Sure. I think, my response, it's so many similarities. I'd love to take it even to the clinical space. So when we talk about language and how important that is, and I think, Jeffrey alluded to, even when you come in the front door, how important inclusive language is so important to stigma and being able to reduce stigma. I think, as Carmarian said, in the clinical space, we were thinking about holistic sexual health, right? There's this exceptionalism with HIV that has been necessary, but in certain ways can still make it feel very separate. And I want, women seeking family planning services or an OBGYN or are women of trans experience who are getting gender affirming care, though, like a one-stop shop, that space where you go already for care, or your primary care provider for treatment of your diabetes or hypertension is a place where you can get an HIV test, is a place where you can have that conversation about PrEP, is a place where you can be started on rapid ART. I think in the PrEP space, it's so important sometimes that even when people come in and ask for it and advocate for themselves, the providers have a discomfort and don't necessarily have the training that's important. So I think here at CDC, we've been thinking really critically about how to support our providers that aren't in the quote unquote traditional infectious disease space so that more holistic sexual health can really be implemented, because I think that's also extraordinarily important when it comes to breaking down this stigma. Where are people already seeking care and adding this to it rather than adding something extra where you have to go for HIV prevention and testing services? The last thing I would say is I'm really excited to see, long acting art and long acting PrEP and what that could possibly mean. But if, what we've seen with one pill a day, PrEP is any example, there's still a lot of work we have to do. Our most recent report and the disparities that we see in PrEP among white individuals who could benefit from PrEP and Black and Hispanic individuals who could benefit from PrEP not only remain the same, but continue to widen. So there's a lot of work that has to be done to help reduce these disparities. But I am hopeful that long acting art and more innovations, as we've talked about HIV self tests, really finding critical, new, novel ways to meet people where they are and where they want to be will help us get closer to ending the HIV epidemic. You're back, Victorian.
I don't know what just happened, but the devil. See, Carmarian and Jeffrey went talking about Jesus and God, and then the devil was like, "Nope, kick him out of here." I don't know what happened. I'm so sorry about that. All right. So do we have any questions, any additional questions that from the audience or anything? Or am I kicking this over to you, Kenyon? Okay, no questions. All right. So while I am here, I just want to thank you all for joining in this conversation. You all have dropped some really important gems in this conversation that I think, that gives us some action items, right? Some call to action to move forward with and see how we can implement these things in our respective functions as we continue to work through and dealing with HIV, particularly in the South, in commemoration of Southern HIV/AIDS Awareness Day. With that, so I would like to. Let's go this way. How about if each one of you can say what would be one of your, if before folks leave out, if they don't take anything else from this conversation, what would you want them to take from this conversation from your perspective? And we will start from Dr. Moulton, and then I'll go down by the line on my screen.
For sure. Thank you again for this important conversation on this day. And one takeaway that I would have to say is that we are all HIV possible. We are all HIV possible. And when we change the language about how we even how we talk about HIV itself, that is one of the ways that we will eliminate stigma. So we are all HIV possible.
Thank you for reiterating that. Carmarian.
Yes, again, so thank you for this opportunity and for this esteemed panelist. I think that my takeaway, being that it's Southern HIV/AIDS Awareness Day, that we revisit to make sure that the work we're implementing out in the community, that it also has a cultural reach to it. That's going to be very important here for the Deep South. We alluded to earlier around Black church, but there are other intersectional things that certainly we can tap into in order to get a great response and identify those respondents that need the services that we're putting forward. There is still a huge stigma that is circulating, whether that's HIV and intersectional around gender identities, sexual orientation. So we're going to have to actually think of a wonderful ingredients. In the South, we cook real good with grease and butter at the same time. But that's a cultural thing. And it's important that we relook at how we're doing this work to make sure that we're touching everyone that is in the South, because we need more numbers in an army showing up to help us combat HIV.
Thank you. Jeffrey?
Sure. Thank you, Tori. And thank you all again for allowing me this opportunity. It's been a wonderful experience to be part of this conversation today with my comrades. I'm going to say this, and I didn't say this earlier, so it sounds like I'm coming out of the blue. I think that we need to really focus with intentionality on the core reason that we have an HIV epidemic. I think in 2010 at the International AIDS Conference, there was data released that showed this strong correlation between poverty and HIV, and then between poverty and Black folks, indicating that by the time we're 75, 9 out of 10 Black folks have lived in a state of poverty. And because of this direct correlation between poverty, HIV, and poverty and Black folks, that's one of the reasons why we're continuing to see this struggle with reducing the number of new transmissions of HIV among Black people, particularly in the South, where poverty is such a heavy issue and lack of health insurance kind of pours out of that. And I think that we have to empower our communities to vote in our best interests, to research candidates, to push for economic change. Because whether we are really aware of it or not, the economics of the world, the economics of the United States, the economics of the South are directly tied to the way the HIV epidemic shows up in the South. We're going to have to address poverty, and in addressing poverty, we'll begin to address the other social determinants of health that are critical to ending this epidemic.
Thank you, Jeffrey. Last but not least, Dr. Fanfare.
Thank you so much once again, Torian, for moderating, and to my esteemed colleagues. It was a pleasure to be here with each and every one of you today. I think if we're talking about one action item, because there's so many, a statistic that always really sits with me is that 70% of adults in this country have never been tested for HIV. And I'm a firm believer that knowledge is power. And people in the South are less likely to be aware of whether they have HIV or not. So earlier on, I talked about Together Take Me Home, which is free, fast, something that you can get, an HIV self-test kit. Please either bring it up with your doctor, call your local health department. But knowledge really is power. So one of my action steps would be for any of those people listening who are part of that 70% to please take the steps to get an HIV test.
Thank you so very much. All very good, valuable action items that we can take with us. And with that, I am going to kick it over to Kenyon.
Awesome. Again, thank you all again for this great and impactful discussion. Few things we want to note, right? So what can you do to reduce the burden of HIV in the South, right? You can start having healthy conversations about HIV. Be the change you want to see. Share testing, treatment, and prevention resources that's available within your community, with your community. Stop the spread of stigma. When you hear or see inaccurate information, speak up and speak out. And of course, for more resources, you can also visit the CDC's website, the Stop HIV Together campaign, cdc.gov/Stop HIV Together. And if you'd like more information on the Southern HIV/AIDS Awareness Day, you can visit the cdc.org/HIV/library/awareness/shad.html. There's a lot of slashes. Again, I want to thank the CDC team on behalf of the Center for Black Equity and the Capitol Ballroom Council. I want to thank the CDC and Chantel and Melissa at the team of WestEd for reaching out to begin this and have this conversation. And thank you so much. Thank you to our panelists, all of you. I know all of you, and we work together. This is great to have everyone together to have this conversation. Again, if you're watching this right now, you have the questions. If you're watching this an hour later, 2 hours later, or next week, if a question pops up, feel free to drop the question. We'll try our best to get you information. Once again, thank you all for joining us this evening, and take care. Bye.
Thank you.